All right, it looks like our numbers are rounding off now. So we'll get started slowly as people start or continue to join. So welcome everybody to today's webinar. My name is Emily Clark. I am very pleased to be your moderator for today's session. I'm a knowledge broker at the National Collaborating Centre for Methods and Tools, coming to you from Hamilton, Ontario, which is located on the traditional territories of the Mississauga and Haudenosaunee Nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. I am happy to be joined today by Dr. Peter Selby from the Center for Addictions and Mental Health, who will be presenting on the Lower-Risk Nicotine Use Guidelines. Before we dive in, there's just a few housekeeping items to cover. Where possible, we recommend using a wired internet connection. If for best results, we recommend you use the latest version of Google Chrome or Firefox internet browsers. If you do have any technical issues, please send a private message to Alana Miller from the NCCMT. She is online and available to answer any tech questions that you might have. We ask that you use the Q&A and the chat to post questions or comments throughout the webinar. Any questions that you would like answered during the Q&A session can be posted to the question and answer field. And make sure that any questions about tech difficulties go in a private chat to Alana. We will also run a few polling questions throughout the session, and we'll make sure that we walk you through how to do those when those come up. After today, the slides and recording will be available in about 2 weeks usually. The recording will be posted on our YouTube account and the slides will be posted on our SlideShare account. We'll make sure that we send out some tweets when those are posted, so it's handy to keep an eye out on our Twitter at NCCMT. And as I mentioned, here are a few polling questions to get us started. We'd like to get a sense of the audience joining us today. First of all, we're interested in seeing how many people are joining us. We know that many are still working from home, but if you are perhaps in the office or watching with a group, we would like to capture those numbers as well. We're also interested in whether or not our audience has previously used the NCCMT site, or any of our resources, and if yes, whether you're a new user or occasional user, or perhaps an NCCMT veteran. Please make sure that you select your response for all 3 questions, and then make sure that you hit the submit button so that the answers get recorded. And I see that answers are coming in. So thank you so much to everybody who has responded to that. Before I pass it over to Dr. Selby, I would like to introduce our center and our sister centers. The National Collaborating Centre for Methods and Tools is one of 6 NCCs, or National Collaborating Centres, across Canada. We specifically are hosted by McMaster University in Hamilton. And our goal is to support public health professionals and organizations integrate evidence-informed decision-making into public health. The NCCs are all funded by the Public Health Agency of Canada. We each focus on a different topic area of public health. So for going from west to east, we've got the NCC for Indigenous Health in Prince George, British Columbia, the NCC for Environmental Health in Vancouver, the NCC for Infectious Diseases in Winnipeg, the NCC for Healthy Public Policy in Montreal, and for Determinants of Health in Antigonish, Nova Scotia. At the NCCMT, we do offer many products and services that can support public health professionals in engaging in evidence-informed decision-making. This includes a registry of methods and tools with almost 300 resources, online learning opportunities, including our 13 online learning modules. We offer workshops, now mostly virtually. Public Health Plus is a repository of public health research. Our video series include the very popular Understanding Research Evidence videos, which go through important concepts to research in short and easy to understand videos. And we also engage in quite a bit of networking and outreach to make sure that people working in public health across the country are aware of the resources that we have to offer. So I am now delighted to introduce today's presenter, Dr. Peter Selby. He's a senior medical consultant and clinician scientist at the Center for Addiction and Mental Health, better known as CAMH in some circles. He's the Giblon Professor, Interim Vice Chair of Research, and Director of the Mental Health and Addictions Division in the Department of Family and Community Medicine at the University of Toronto. His research focuses on innovative methods to understand and treat addictive behaviors and their comorbidities. So we're very excited to have him present for us today, the Lower-Risk Nicotine Guidelines. And with that, I will stop sharing my screen and let Peter go ahead and share his slides today.
Thank you so much, Emily, and really a pleasure to be invited to be able to share this information with you. Bear with me as I try to share my screen with you and make sure it works. So let's see, there it is. I think you can see it, and I'm going to go into presentation mode. Hopefully it will now show the slides. And are you able to see my slides, or are you seeing the slide view?
It looks good.
It all looks good. Okay, wonderful. So thank you again. And I'm going to start off with our land acknowledgement at CAMH, which is covered by Treaty 13, and Toronto is now home to a vast diversity of First Nations, Inuit and Métis, who enriched the city, but originally it was CAMH grounds, which is at in the west end of the city. Did appear in the Colonial Records Office of the British Crown of the Mississaugas of the New Credit, as they were known at the time. More importantly, is we are also committed to reconciliation, and we continue to honor the land through programs and places that respect and reflect its heritage. And I'm going to focus, obviously, on tobacco, and we really need to understand that when we're talking today, there is something known as ceremonial tobacco, which is very different. It's a different product. It's a different plant, and its use is very different. And so that is really not what we're talking about today. And so we are going to be talking about the issues of the harms that have been caused by commercial tobacco and its commercial tobacco use and the addictive nature of it, and the harms that it has caused countless of people across the world. Which cannot be, the same cannot be said on the use and the way ceremonial tobacco is used by some indigenous communities and as a sacred plant. So I think with that, it's really important for us to think about how we talk about this and how I talk about these lower risk nicotine use guidelines as well. My disclosures, for this particular talk, the funding for this talk, for this work came from Health Canada through the SWAP grant. But in terms of no tobacco, alcohol, food industry, or vaping industry relationships, I run the STOP program and developed it and run it. And for that, we go through an open tender process and buy nicotine replacement from Johnson & Johnson, Novartis, through an open tender process. And through some investigator-initiated studies, we have had Pfizer provide us varenicline for studies. Nothing in the last years, or nothing current, I mean, for Pfizer. And then the other companies that you can see there are unrelated to the topic of today. So 3 learning objectives that we want to get in, and one is really describe the broadening landscape of tobacco epidemic that necessitated us to create these guidelines, investigate the formulation of these guidelines, and then examine the recommendations and a dissemination plan. So what's going on? Why do we need these lower risk nicotine use guidelines at this time? Well, one of the things that working in the field of addictions, which I always found odd in Canada, was public health and the rest in this field was very open to harm reduction and a pragmatic approach to harm reduction when it came to things like alcohol, illicit substances. In fact, that's where you saw the legalization of cannabis, etc. However, and I work in those spaces. However, when you work with tobacco, somehow it was a quit or die, very abstinence-oriented approach, and made sense because that approach that really helped bring the prevalence down a lot. But if you take a step back, most of the policies that actually worked towards reducing the harms from tobacco and reduction had a lot to do with reducing and protecting others. So, indoor bylaws or smoking, or price increases, etc. None of them actually said you have to quit. It's just basically reducing the number of consumption and reducing the harm from the product, even though the product didn't change. So it was really, I found it really odd. But, obviously we continue to work with that, and then those are important things to do. But this idea that, clinically seeing people who are unable to quit really struck me. And despite the best efforts, they were unable to quit, and they were coming to harm from their smoking. And so all of us, most of us, have seen people like this who are unwilling or unable to quit. And what do they look like in, oops, this is not going forward. What does the current state look like? So 2019, we've really brought the prevalence down. It's still a large number of people, 12% of Canadians. And youth are still coming into it, even though prevention has been working really well. We got 5% of youth still smoke, but the bulk of people who are currently smoking in the millions are those above the age of 25. And this group is continuing to acquire the risks from tobacco. Who smokes? Mostly men versus women. Although women appear to have a greater harm from tobacco than men. And again, the other forms of tobacco, cigars, water pipe, and chew are really, they are there, but they are not the major sources of exposure. But what really took off was vaping devices. And vaping devices, as you know, started out in 2007 when they were invented. And the original ones were more like novelty, but the interesting thing is that the innovations happened so quickly that you landed up with this really high potency, salt-based, pod-based system, most commonly known as Juuls, which came out and really took off. And regulators were not ready for it, didn't know what was happening. And the usual idea of let's ban everything wasn't working. So, when you look at StatsCan in 2019, 5 million people have tried it. That's lifetime ever vaped. But what was very interesting is there's 5%, about 1.5 million people in the last 30 days who vaped. And 38% were current smokers, 25% were former smokers, and that is concerning. And 37% were never smokers, which made it really concerning, with 84% of them responding saying that they'd use nicotine. So this is obviously starts, wow, what's going on here? But if you take a look at that, and then contrast it with the people who are daily vapers, it's really small comparatively. So of those who've ever tried, it's really not that many compared to, it's a little bit more than 10%. So what's going on there? Now, when asked why people vape, it's, about 27% to quit smoking, 20% are curious, and 20% just like it. So what's going on then? And what's the risk here? I mean, this could undermine tobacco control greatly. But we also have to put this into the context that tobacco smoking, as we know, most of the harm from cigarettes come because people inhale 7,000 chemicals, 60 carcinogens, and nicotine is a minor component of the overall harm being caused. It causes people to get addicted to a bad product. But really, it's the delivery device that is problematic, and as a result, you get this economic burden from tobacco smoking, which is about 18.7 billion annually, and that's in 2015 numbers. Globally, that's in Canada alone. But globally, if you look at healthcare expenditure due to smoking attributable diseases, $422 billion in purchasing power parity in 2012. And that's 5.7% of total global health expenditure has to do that. And if you take a look at economic cost of lost productivity, you're talking about $1 trillion, equivalent to 1.8% of the world's GDP. So it's not cheap to let and allow this product to continue. It's over 100-year-old technology that is being used by such a large number of people, which makes little sense. So as we talked about, nicotine is the addictive component in tobacco. And clearly, when we start looking at it, are there alternative ways for people? If we adopt a harm reduction kind of approach, is there an alternative approach to letting people have access to nicotine in a way that doesn't cause the individual and societal harm that we see? So obviously the original says, why don't we just get everybody to quit? And clearly quitting smoking in Canada, and if you look at what has happened to the curve and that reduction, prevalence reduction, did not happen equally across all populations. And certainly some populations have been left behind where their prevalence is not at that 12%. They are much higher, especially people who are socially disadvantaged, people who have less than high school education, those who live in poverty, those who have mental health and other addiction disorders. Their prevalence continues to remain 3 to 4 to 10 times higher than the general population. So if you take a look at quitting, it seems like we've come to a steady state where those people who are going to have quit have already quit. So in 2019, majority of people have reported being a former smoker, but 3% only quit in that previous year. And the other thing that emerged was previously you would get data which would show 70% would quit on, most people would quit on their own and would not attribute any kind of help. They have tried previous times, but then their final quit was on their own. And others were like tapering or reducing the number of cigarettes. And 35% switched to vaping. And that was a concern that this is happening. What is this phenomenon happening out there? And clearly this is happening outside of the health system. And what was happening in our TEACH, so TEACH, as you know, is part of our learning health system with tobacco, where we have STOP, which is the implementation arm, into about 350 settings in the province and counting. But TEACH is the education arm. And what was coming through the TEACH listserv, as well as through the communities of practice that we have, was we are getting people who are coming to ask about vaping. We are getting people who are getting addicted to vaping. We are having people who want to stop vaping. We have people who want to start vaping, and we don't know what to tell them. Where's the guideline? So all of this was starting to come together to create a need for us to figure out some guidance. So we were always pushing more cessation, and I think we should continue to do that. But the challenges with cessation are that for the bulk of people, we see, a small fraction of people. So for example, STOP has been in operation since 2005, and we have treated in Ontario over 300,000 smokers. But when I step back and look at that, yes, that's only 10% of people. That's only 10% of smokers in Ontario. So, or a little bit more than 10%. But what about the others? What about the others who aren't interested? So one of the problems is people don't have knowledge and beliefs in the harms of smoking. They may not even want to get help with, they don't believe they need help or using meds to quit. So they continue to use cigarettes and continue to come to harm. Moreover, even if they do come into clinical systems, the attitudes and knowledge and skills undermine the efforts. I mean, as it stands now, most of our health data does not document people's smoking status in hospitals, in clinics, in EMRs. There is no good way to do these. So if the whole system is not paying attention to it, there's a problem. And most providers don't know how to help people to quit. And then there's obviously the problem of coverage and accountability in these areas. So there's a lot of issues that come in the way of cessation itself coming into the hands of people. So our service, which is essentially a learning health system for tobacco use, is we really want to do two things. One, increase access to free treatment for Ontario smokers, either through nicotine replacement or prescription, and as many as possible, and obviously build the system and practitioner capacity to make sure that they help people effectively. And overall, work within the context of decreasing the prevalence of smoking in Ontario, keeping that 5 by 35 in mind. So that's the background as to why, in the absence of this emerging phenomenon, in absence of good studies, could we really come up with some guidance or guidelines? And SUAP approached us, Health Canada approached us through the SUAP, and that's how we move forward with it. And we said, look, we really can't prepare guidelines based on grade that would have high quality evidence with multiple randomized controlled trials for each of the questions, but we do have a methodology that can help guide and create some guidance that starts off with the idea that here's where we need to start, and then we will iterate as more and more evidence comes to light. So what you're going to hear next is just how we came to this process. And as you can tell, we had to bring together people who are completely abstinence oriented and believe that people just should quit, and there's no room for vaping devices or alternatives for people to reduce their harms. And then you had another group who are saying, let's be more pragmatic about it and say, yes, we are seeing these people unable to quit. Can we actually offer some guidance for them? So we try to put together as much evidence that is there on how people could lower their risk when choosing or using nicotine products. And that's really, this guidance was to really understand that, yes, we accept that there are people who are using products. If they are going to use it, how can they're interested in lowering their risk, what are the things that they can do to lower their risk? And educate and empower lower risk nicotine use. So even if you're going to use a product, what you don't want is people to compensate. So for example, people who say, well, vaping isn't that bad, and so I'm going to vape more than when I was smoking, which was more harmful. So you don't want that compensation or risk compensation to occur. So that's what we wanted people to know. And that is the purpose of why we went around this. We tried to say, okay, let's anchor to something. So we wanted to be guided by great principles. We had a guideline development group formation. We developed a research question. We had collected priority topics, and we also reviewed the literature. And so we did 3 rounds of literature search. This was in partnership with the Centers for Effective Practice. We did a system of systematic reviews, supplementary e-cigarette RCT research, and then up to the minute literature search was done. And the quality assessments employed the agreed-to instrument for clinical practice guidelines and the AMSTA instrument for systematic reviews. And really, because of the limited nature of the e-cigarette study methodology, we couldn't use the full AMSTA would have got us very, very, very small number of systematic reviews. So we did a rapid AMSTA using 2 key metrics, that is a comprehensive literature search and assessment of scientific quality of the included studies. So we were able to include many well-done studies, but they would not pass the high of a full AMSTA while excluding the less rigorously performed reviews. So, we, when the guideline development group got together, we realized that we would only land up with 1 review. So we did another lit search to target the high quality RCTs that were published between 2015 and 2020. And we used the Cochrane risk of bias tool to assess them. And so this is pretty much how we went. And then we did a secondary up to the moment search was conducted in Jan 2021 to ensure that the recommendations were supported by available literature up to that date. So we used a secure anonymous voting tool to vote on necessary changes to the recommendations, including level of evidence and strength of recommendation. So this was an adaptation, paying attention to the evidence base, the extent of the evidence base, and how can we make the best informed decision with what is available. So what are the literature review? Vaping evidence is emergent. Many systematic review, not for, as I said, and I already covered that. So we did a 2-day in-person meeting in Toronto, and we had presentations and recommendation development, and these 2-day meetings happened prior to the pandemic, so we got that in. And here's the group. We did some purposeful sampling from across the country, and this is the group that came together, many of them, and all their disclosures have been released. And at the end of the day, basically, we've got the Ontario Tobacco as organizations, Ontario Tobacco Research Unit, Pharmacists for Smoke-Free Canada, and CAMH, who have worked on this and have agreed to endorse these groups. So if any of you are in the audience, thank you so much for your participation. So as you know, guidelines have level of evidence, very low, low, moderate, high, quality of evidence available. And as I said, the rapid AMSTAR review. And the strengths of the recommendation, we said strong, conditional, confidence that adherence to the recommendation will cause good, and quality of evidence and GDG expertise was used to help come up with those things. So what did we come up with? So we do think that the overall literature just say that what people use will affect what kinds of harms they come from, how much they use and what they use. So for example, you know, it's not a difficult experiment. Tomorrow, if we got rid of all combustible tobacco and people used only oral forms of tobacco, you would pretty much eliminate any new cases of COPD and probably eliminate lung cancer because no more inhalation. So that's, but the consumers are not using chewing tobacco, they're using cigarettes. So we know that those things could be modified, and there are certain evidence that people are switching to them. Now, it's not to say that, you know, chewing tobacco is all 100% safe, but just to give you an idea that when people are making choices about something, and of course, those choices are determined by social determinants and the availability and the marketing of products, but the type of product will make a difference. Now, what we wanted to come out with is that really, this is to really first out the bat say that full abstinence from nicotine products is the only way to completely avoid the associated health risks from tobacco, obviously. Quit or reduce to quit with pharmacological or behavioral supports is always encouraged first. So this is not your, you know, last thing to come to. You want to make sure that people are advised to quit or reduce to quit with evidence-based interventions. And for those who choose to use nicotine, health risks and outcomes are modifiable through their choices that they can make around which products they go. So what do the recommendations say? And really, these are where we have, where you know, push comes to shove, the issue of smokeless tobacco, that the recommendations came out were use of smokeless tobacco should be discouraged. And the level of evidence is actually quite low. But the strength of their recommendation was strong because the committee felt that, look, we're not talking about snus here, we're talking about what's available in Canada and North America, and that form of tobacco cannot be promoted as one. The other next product that came up were the heated tobacco products, which are kind of tobacco industry's variations of, you know, of e-cigarettes, which instead of having the nicotine extracted and put into, you know, into vegetable glycerin and propylene glycol mixtures and heated tobacco products actually heat tobacco. And again, the use of heated tobacco products should be discouraged. The level of evidence was moderate, and the group felt that it was strong. We should strongly discourage people from using these two products. Similarly, for water pipe, high level of evidence that it should be discouraged and strength of recommendation was strong. And the impacts of these products, smokeless tobacco, heated tobacco products, and water pipes on reproductive health, interestingly enough, because there isn't enough published data, the level of evidence is very low that we should be discouraging it. But the committee felt it doesn't make sense to say, yeah, if you're pregnant, you should be using these things, but not otherwise. But this is one, the group really felt that we should come out strongly about this. I'll switch mostly to vaping because that's the hot one that is capturing people's minds and is on top of mind for everybody, is recommendation 5A. So one of the things is that we wanted to make sure, as we saw those data, that young people are taking up e-cigarettes with nicotine. We need to discourage the use of e-cigarettes with nicotine among non-smokers because they can get addicted to it. And so really not to do that. Now, of course, you don't want to only discourage e-cigarettes and have people walk away thinking that regular cigarettes are better, which unfortunately then leads them to using regular cigarettes. But so the message needs to be really clear about things, that if you are a non-user of nicotine, no matter how, as a young person, don't start. Doesn't matter whether it's vaping or cigarettes, just don't start. So that we want to be really clear that happens. And the summary statements around that was that clearly there's good biological evidence and epidemiological evidence that e-cigarettes with nicotine are addictive, and people will end up with symptoms of dependence on e-cigarettes. Also, what is emerging is that the use of e-cigarettes also increases the risk of ever using combustible tobacco cigarettes amongst youth and young adults. And however, having said that, the transition to regular use of tobacco cigarettes is unclear at this time, which means the evidence base for that gateway hypothesis is really, the evidence isn't strong that it's a gateway hypothesis for everybody who tries e-cigarettes. And there may be genetic or other social demographic vulnerabilities of certain individuals who land up then transitioning between e-cigarettes, cigarettes, and other substances as well. But it's not an inherent factor in e-cigarettes that sensitizes them to regular cigarettes. One of the other considerations is, as we talked about Juul, which is now less and more about some of the other tobacco industry developed e-cigarettes and pod-based systems, is that this idea of high-dose nicotine salts, and many jurisdictions, and of course the concentration of high-dose nicotine has been brought down, but the high-dose nicotine salts may increase risk of addiction, and we were seeing that, and so we wanted to make sure that people understood this, that the higher the dose of nicotine in the cartridge, the worse you're going to get addicted, and that we need to advise youth and young adults that this is addictive, and again, you may transition into cigarettes, so don't do that. Don't transition. If you do, try it. The other one is, just because people can vape, and I know people have called it a vapor, but it's actually an aerosol that comes out, then people should vape in areas where they would smoke, but not otherwise. So try not to smoke, vape around others, especially indoors, just so that you protect them from the airborne particulate matter that comes from vaping. The other question is vaping and cessation. So one is, so that absolute risk from vaping, we felt the guidelines could make sure, prevent never smokers not to take up vaping and be really clear about it. But then what about those smokers who have tried everything or are unwilling to try any of the behavioral or pharmacological issues? Should we be asking them to use e-cigarettes? Or if they want to use an e-cigarette, what do we tell them? Can an e-cigarette help me quit? And the overall recommendation and the evidence suggests that e-cigarettes with nicotine may be an effective cessation aid for people who use combustible tobacco, but there are some caveats with that. So the systematic review did provide some evidence that they could be used as a cessation aid, but remember, none of these vaping devices that are studied are necessarily available now. But in general, what we do know is that the more frequent use of the e-cigarette, the greater likelihood that they will be quit. So, and again, if they really should pick this after they've tried approved cessation interventions and medications and other treatments before they do this. And again, if they're unable or unwilling to quit, then they may be considered. Of course, we had a lot of considerations for people to look at. One is that if you're going to try to quit, combine it with the behavioral counseling. It isn't just telling people, go to the vape shop, buy the e-cigarette and use it. And I can tell you in our clinic with some of our heavily dependent users who go off and do that, they get all sorts of information and often don't stick with the program because they don't understand how it's required to be used. And so we really try to encourage the counseling along with it. The other piece is this issue of preventing dual use, which means smoke, you have to advise them to switch completely from their combusted tobacco cigarettes to e-cigarettes and use the e-cigarette when they normally would have smoked, but not, oh, when I cannot smoke, I'll vape, and when I can smoke, I'll smoke. That is probably worse because they'll end up having a higher exposure than to either one alone. We could not make any recommendations about the device type and nicotine dose and left it up to personal preference because there are too many devices out there. There are too many different brands. We don't know which one's going to stick and stay around, and none of them have been approved by Health Canada in the first place. So, as a medication to quit, we really can't be cannot advise on those. So really, when it comes to these device types and nicotine dose, it's a personal preference. We also wanted to be pretty clear that the overall evidence suggests that if you are a tobacco user, a smoker, that switching completely to an e-cigarette will significantly reduce your harms over time. But we also need to be mindful that the ultimate long-term harms with long-term e-cigarette use is currently unknown. We know what the health effects of inhaling nicotine are, but what we don't know is the long-term health effects of exposing your lungs to propylene glycol, vegetable glycerin, flavorants, and other heavy metals and other compounds that might be in a vaping device, especially if people compensate in the sense that they're continuously grazing through the day, exposing themselves to large amounts of these chemicals. We have no idea. And based on one of the studies, that the continued use of e-cigarettes may reduce the risk of relapse to combustible tobacco. And so, as you know, people who quit smoking with or without help, 60 to 70% of them will be relapsed within 6 months. And so if people, and one study in the UK showed that people who were really successful at staying quit were those who continued to use e-cigarettes for a longer period of time. So and they were able to then not go back to cigarettes. So that is the considerations when looking at vaping for cessation. We were also asked to think about vaping and health outcomes. So if you vape, what are some of the health outcomes that you have? And so the recommendation is very clear that if you do not use tobacco products, please do not use e-cigarettes. It isn't something that everybody should be trying. This is not one of those things. Oops. Yeah, and again, people who are currently using e-cigarettes should stop or switch to safer forms of nicotine, such as NRT. Now we had a lot of debate about this one because on the one hand, we are saying, if you can't quit cigarettes, switch to vaping devices. But when you switch to the vaping devices, we are saying, get off the vaping device and get to another form of NRT. A lot of this and these recommendations need to take into consideration where that person is on their journey. So once they are stable on e-cigarettes, then we're helping them switch or to a safer form of nicotine or to stop vaping is part of that journey. It's not a one-off kind of intervention. The people who do switch, we did talk about this. People who switch from combustible tobacco will reduce their exposure, and that there's no doubt. We didn't want to go like Public Health England and say there'll be a 95% less or a number. We think the truth lies somewhere between potentially 70 to 90%, but we have no good way of confirming that, but that's what the sort of consensus lies. Again, we did talk about e-cigarettes being a lower risk alternative, and the summary statements is the caveats, which is long-term health effects unknown. There is some evidence of mutagenesis and DNA damage related to e-cigarette use that is a marker for increased cancer risk. So we cannot just say, this can be ignored. It may help reduce those risks from tobacco smoking, but our biggest concern is making sure that this doesn't get into the hands of the never smoker, who now lands up with increasing their risk. And of course, we do know that people who use e-cigarettes do get a cough and mouth and throat irritation as well. And so it's not completely benign and innocuous. There are local effects as well. Again, as you can see, this theme that they're not completely harmless keeps coming out in all the considerations, and we have a lot of unknowns there. But whatever we said is that if people are going to use these products, make sure they use the instruction or use it as instructed in terms of whether they have to replace certain parts or wicks or dispose of certain parts, etc., because there are lots of variability in device and types. And that's where we felt that people need to really make sure they get instruction. In terms of individuals, we felt that they should know and consider the following. One, do not purchase unsafe, illicit black market e-liquids pods. Do not adulterate it with THC or vitamin E or other oils to prevent the EVALI, which was happening, which is a severe lung disease that can occur. And of course, keep the products away from children. And again, the combined risks of using e-cigarettes and combustible tobacco concurrently are unknown, other than the fact they're getting more exposure. We don't know what the harms are. So that took a lot of review of literature and discussions around the table, but I can tell you we were able to come to consensus. So what you're seeing is what everybody came and were able to come to consensus with it. So out of all of that work, the team distilled it down into 3 products. And these are the products at a glance. The first product are the recommendations with the summary statements and the considerations. And the second product is obviously the evidence briefs to make digestible recommendations, a little bit more for the practitioners to take a look at, to understand what the evidence behind it is and get them to know what the evidence brief is that lies behind these recommendations. And the last one is the quick tips, which are for individuals and the lay public on how to lower their risk when using nicotine and chart of product contents and health risk. And again, this is to be in a non-judgmental way, help people make an informed choice about their use of nicotine products. So as I mentioned, the recommendation document is used that it's meant for the healthcare practitioner. It contains all the recommendations, and there are links to the executive summary and methodology and full reference list. Again, the evidence brief, as I mentioned, is healthcare practitioner facing, makes the recommendations more accessible, and it can be used when a client or a patient is asking questions. They refer to this. And I mentioned this is the patient-facing resource, which gives them the 7 tips and can certainly be shared with their clients. So those are the products. As you can tell, this happened all during the pandemic and it was finalized in 2021. So our dissemination strategy has been in this way, that we're really taking a soft launch approach. In 2020, we started the product creation with partners at Center for Effective Practice. We did some usability testing with healthcare practitioners and consumers around these products in June and July of 2020, and then we finalized them in May of 2021. And so the soft launch, after these products were developed with a lot of end users, people who smoke, people who use e-cigarettes, we felt we were ready to do the soft launch. And so we've had it on our Nicotine Dependent Services website. All 3 products can be downloaded from there. We put it up to the Teach webinars. We've done in the Teach listserv, the Stop teleconferences, Go Through newsletter. And of course, now we are working with NCCMT and CP and the Pharmacists for Smoke-Free Canada, hopefully that it get disseminated. And this today is one example of that strategy of just creating awareness about that this has been created. We're also working on the French translation follow-up surveys on the use of it, and working on getting more funds for that. We want to use the follow-up survey to gauge skill building, feedback, and then we're writing a manuscript about about how this process works when you don't have really high quality evidence, but there's a lot of need for information. So just consolidating that information so that practitioners and lay users can get some advice as to what to use, and balancing that message so that it isn't saying, we're not saying everybody should vape or everybody should not vape. We're helping people make that nuanced decision. And that is really in keeping with harm reduction philosophy and principles. This would not have been possible with a whole bunch of people. The team includes a guideline development group, and that was brought together with our partners at NCP, and Rosa Dragonetti at CAMH, Chantal Fouget, Danielle Dawson, Andrew Bowski, and Sophie Blackmore, and and our partners, and then obviously the funding with support from Pharmacists for Smoke-Free Canada and OTRU. So thank you. And I think that leaves us lots of time for discussion and questions. And I will stop sharing the slides so that I can start seeing the questions and the comments.
Wonderful. Thank you.
Moderating this piece, right?
Yes. Thank you, Dr. Selby. That was a really wonderful explanation. I mean, definitely a more nuanced discussion than it was maybe several decades ago on smoking cessation. So really interesting to hear. I'm glad we do have some time for questions, because there have been quite a few that have actually come in. Most have come through the question and answer, which is great. There were two that came in through earlier in the chat, so I'll take them in order that the questions arrived in. So the first two are from the chat. The first one coming from Crystal. Is there a way to differentiate deaths by vaping or traditional smoking? Just wondering, as Right for Vapors has mentioned this supported by the Lung Association based on an article on National Non-Smoking Week last month.
That's a great question. You know, attributing death, cause of death and manner of death is really, is a lot of debate. I mean, there's problems even in general when people die from, even like, for example, opioids. You know, just because the opioid was present in your system and you died doesn't mean the opioid killed you. The more tricky piece is the attributable fraction. How do you attribute a death? So somebody's been smoking cigarettes for 30, 40 years, now switches to vaping and then dies from a smoking related illness. Is that because of vaping, or is that because of that 40 years experience? Because we know that it takes 15 more years to reduce your risk from tobacco exposure, for risk of stroke and lung cancer, at least 50 to 20 years after you stop. Why is that? That's not because of nicotine. That's because of some of the carcinogens and some of the issues that have been caused that persist for so long. So I don't know how this is going to be teased apart as to whether you can attribute that death to vaping. Now, of course, you can attribute it to the immediate causes of death. So you can say, for example, the number one causes of house fire deaths in Canada are smoking. And so you could compare, how many people have died from, getting burnt through a vaping device. So there are ways to sort of look at some issues, but I don't think you can do it as a blanket statement across.
Thank you. That's insightful. The next question comes from Chase asking, I have heard of people importing snus from abroad. I believe that is a type of dry snuff, specifically from Sweden. Yes. Would you be able to speak to recommendations or the level of evidence around this category?
So Swedish snus is Swedish snus, and it always has to, you have to maintain the cold chain. It's got, low nitrosamines. It has, and absolutely, if you can, it does reduce your risk. What it does is it doesn't reduce your risk to zero. It's much better than if you continue to smoke, but doesn't reduce it to zero. And so, and primarily, if you look at the snus literature, the risk that doesn't drop as much is the risk of pancreatic cancer. So I think the risk goes from 3 times, odds of 3 to down to odds of 2. So it's not huge, but absolutely the risks of other like COPD, lung cancer, all of those things happen. The problem is tobacco companies in North America can call anything snus, so it's a buyer beware that what you're getting in North America snus is not snus necessarily. And the imported snus, you're going to be really careful that it is in fact Swedish snus, manufactured, stored, kept the same way. So really when people are saying they're using snus, you got to figure out what they mean by it. And again, is this using it only when they cannot smoke, or are they using it otherwise? Also, in terms of paying attention to oral health, when anybody has this issue, it's oral tobacco exposure is a great #1 cause of tooth loss, gum decay, etc., like that. So and potentially oral cancer. So one has to be a bit careful about that as well, and needs constant monitoring if they are going to be using any of these products.
Great, thank you. Question in the Q&A from Hannah. Do you recommend that pharmacies who provide cessation counseling also have a stock of vaping products to dispense to avoid mixed messaging by vape shops?
I think this is a great question. I'll tell you here's, so one of the biggest, so currently in Canada, we are completely hampered. So if we as investigators want to go do a research study to look at, is it effective in cessation? We are unable to get the authorization from Health Canada because you need somebody with deep pockets who can then provide all the information, including animal studies, including all sorts of studies, so that we can actually do the study. And Dr. Mark Eisenberg, who's actually one of the people who've done the multi-center studies for using vaping in smoking cessation, had to stop because halfway, and all our future studies, we're not going to be able to go forward because those products change, Health Canada changes, so it's really difficult. Why am I telling you this? If a pharmacy is going to sell a product where you are not confident about its quality, etc., it becomes hard for you to be able to sell it, right? It's and are you able to recall it? And the other one is, now the market share is not held by vaping devices that are not owned by tobacco companies. They're almost all, the big #1 like Ripe and Use are owned by tobacco companies. So now that becomes a problem. So it was very interesting. Till very recently in Canada, there was no tobacco company involvement with vaping devices. And it's only more recently where that involvement has happened. So there are some ethical issues to consider. In terms of the mixed messaging, I think it's again, when we were taking a pragmatic approach, we said we needed to have training. In Ontario, for example, in Canada, we have server training in bars and training in casinos so that people who are servers get trained in how to make sure that they can't do that unless they get the training. We were trying to float the idea like people who sell vaping devices should have some sort of training, formalized and accredited. It hasn't gone anywhere, especially because a lot of vaping devices are sold through convenience stores, and the convenience store associations are very aligned with tobacco industry. So it's very difficult to get this moving forward. But I think there needs to be that kind of pragmatic approach that we took with other substances of server training and other, as a way to make sure that people who are selling these products meet a certain standard to sell.
Great. The next question comes from Lori, asking, how would the guidelines apply to youth? So
other than don't do it, is essentially what we are telling is youth, like, don't vape. Now, there's a whole bunch of sort of evidence emerging in countries where youth vaping has gone up, and in the US, for example, and UK as well. And tobacco smoking amongst youths has gone down, and the switch from tobacco to from vaping to tobacco is restricted to people who have more likely to be using other things. So this is a kid in trouble is going to be the one who switches to other things. But the general message should be, don't vape. I mean, very quickly to say that. But again, as part of what we might need to do is youth is a big age category. It can go from 12, to early young adulthood. So we are looking at what are the next steps and are looking to explore what kind of adaptations may be needed for a more youth-focused specific approach, much like what CAMH did with the cannabis use risk guidelines for youth, the adaptation. So right now it would be, don't do it.
Great, thank you. Please give that message to my kids as they get older now. Next question is, could you speak to the outcomes of vaping that were examined in the literature review and considered in the guidelines? It seems like nicotine addiction and transition to or from combustible tobacco were looked at. Were there any other direct health outcomes?
Yeah, essentially, with the health outcomes, again, the health outcomes are, you don't have long enough exposure. Like, for example, if we looked at the immediate health outcomes of smoking, you wouldn't find anything, a one-year study of people smoking, unless you have some other health condition. But what you do find are these symptoms, and that's what we said, like the cough and the coughing and the dry mouth and all those things, which are immediate, were able to be detected and the addiction piece, which emerges very quickly. You can, but the longer health harms, and that's why we had those caveats, we really can't tell what's going to happen in in users. You can look in labs and that's where all that mutagenesis and all of those things came from, but long term could not answer that question. Sorry.
That's okay. Next question comes from Hannah. Do you recommend heated tobacco products in a similar way to e-cigarettes as a cessation device?
Great question. We actually don't, primarily because when you've got an alternative that doesn't have all those things, then why are you giving people a heated tobacco product, which is like makes zeros, like has more, potentially more exposure? We are doing that when there is something that potentially has less? So again, the committee felt that heated tobacco products we should recommend against that, because, and in many ways now we have no direct proof of this, but based on tobacco industry tactic, we feel that this product came out more as a way to interfere with their concerns on what was happening with vaping, as opposed to really, a really need for this product. It was just one of those things that were just pushed out there. So we're not sure why that happened. And yeah, I think, I would be cautious about equating the two. Although I think the industry likes us to do that, but we weren't.
I think the next question is more for the NCCMT, asking if the PowerPoint will be distributed to participants. It won't be distributed, but it will be made available on our SlideShare account. I'll post the link to the SlideShare account in response to the question. Usually takes about a week or two to get that online, because we translate it into French and post the French one at the same time. And we'll always post on Twitter when we have made an upload to SlideShare. So I have sent that answer in, and hopefully you'll be able to find that. It's also in the chat if you scroll up. And the next question again for Dr. Selby. As there's no evidence for NRT, nicotine replacement therapy dosing for vaping cessation, what is your recommendation? Would this be considered an off-label use? As a health authority, we are restricted in making recommendations in regards to off-label use due to the lack of evidence and possible risk of liability.
Great question. So actually, Ontario Ministry of Health just tasked us this last year, and we're just tidying up that one, was to develop guidelines for vaping addiction or nicotine addiction. And we got an international group together to do some consensus building around what it could be. So you're absolutely right. There is no evidence for using nicotine dosing. And again, the variability of the products, you don't know what kind of dose. So pragmatically, what we tell practitioners is, if you are going to use a nicotine product, first try to get them to taper with whatever vaping device they're using in terms of the concentration and time and frequency, and help them do it like a fading. If you are going to give them a nicotine replacement product, at least in the first week, get them to switch completely to a short-acting product, which of defined, whether it's a lozenge or gum or inhale, what they're getting, and then switch to a long-acting, because otherwise you may make somebody sick. So that's where we would say, and interestingly enough, nicotine replacement products do not have a label. They don't even have, they are a natural health product. So one has to take a look at it slightly differently. So I don't know whether natural health products have a label, like a potential label, but yeah, if you want to look at how you handle in your health authority, handle natural health products. And the third thing I would say is, and we've had to do this here as well, the decision-making, even though we may provide the nicotine or the nicotine replacement to the practitioner, at the end of the day, it's the practitioner's decision how they do it. So allow the practitioner to make the decision, because a lot of times, I mean, for example, many conditions. For example, if somebody develops COVID now, and somebody needs to use, say, for example, budesonide, which is an inhaler, that's off-label. But that, but the recommendations have been made by the science table, and then practitioners do what they need to do. So that's where that's how we would handle this thing. And we think that there is, and the question is, what's the liability from nicotine replacement? I can tell you, we have enough data and use in the world that nicotine replacements are essentially safe for all. So, and what's the worst that could happen? Somebody might have an acute short-term, side effect. But anyway, I hope that answers your question, but stay tuned for the Ontario version. We are hoping to have that out soon and share it with everybody.
That's great. Very interesting question. Very great questions coming in. The next one we have is that many clients seem to think that e-cigarettes and vaping nicotine are safer because the harmful part of smoking is from the tar and not the nicotine itself. Will the restatements or parts of the knowledge translation products addressing this common myth?
Yeah, so the myth is that, I mean, that most of it is the tar, right? The products of combustion. So yes, from that perspective, in the short term, they are safer. And that's what we want, that information to be made available. And that's what the guidance would let people know, that, yeah, the risk. And so when they look at it, they can see where that risk category lies. I mean, with that.
And then related, an attendee notes that sometimes they read that nicotine is carcinogenic and sometimes that it's not. Are you able to elaborate on this?
Yeah, so nicotine by itself is not a carcinogen, but it is what is known as a pro-carcinogen, in the sense that if somebody has a carcinogenic thing going on, it can help promote cancer, because it creates what is known as prevents apoptosis, which means cell death, and it allows abnormal cells to continue. So it doesn't cause cancer itself, but it kind of is like your friend of cancer. So that's why it is, we really want to make sure we're telling people, like, look, it's, it's definitely, that's why we're saying not everybody should be using nicotine, because it has this pro-carcinogenic effect.
Right.
But it doesn't, it's not a cancer chemical itself.
Thank you. That is, I had definitely heard the myth about tar as well, so good to know. Something helpful for clients from the low-risk alcohol guidelines is an actual quantity or standard drink level recommended to minimize harms. Of course, it's controversial to do so for any substance, but was there consideration of looking into quantifying levels of nicotine exposure that causes poor health outcomes to be able to provide a similar recommendation?
That's a great question. And no, really, this was looked at dichotomous, exposure, non-exposure. Amount of exposure was not easy to pull out or look at. I mean, usually exposure levels look at something called pack years, and that was a way to look at exposure, number of cigarettes smoked, for the number of years divided by 20 to make it a standardized pack year. And that's how we got up the risks for COPD and lung cancer, et cetera. But with vaping and other things like that, or we don't know what the pack year would be, or we don't know for chewing tobacco what that would be either. So, but that's a great question. We just don't have a good answer for that.
That makes a lot of sense. I guess if you don't have a standard unit, it would be very difficult to measure.
Yeah.
Next question came in several parts, but we'll go through it. So it looks like currently Health Canada is seeking consultation regarding proposed single-use plastics prohibitions. Unfortunately, cigarette butt and vaping e-waste are not included. Cigarette filters have been marketed in a less harmful cigarette, so the low nicotine risk, I'm trying to come up with the proper acronym there, but the low-risk guidelines make sense. If there was a ban on the use of filters in cigarettes in the ban of single-use plastics, could you please comment how this might impact the consumer choice in cigarette purchase?
So Lori, thank you for that question. This is not, this is not part of our guidelines, but I think you're absolutely spot on. We do not pay enough attention to the waste that tobacco, cigarettes, and butts cost, and the number, and how our waterways are getting contaminated, et cetera, and the beaches, et cetera. So that is one thing. Less so paid attention to what happens with vaping devices, and especially the, if you look at young people, sometimes they'll have 2, 3, they share them. A whole bunch of these lithium-ion batteries lying around. There is no mechanism for their, disposable, recycle. I mean, I don't, we've got good mechanisms for recycling other electronics, and in at least in Ontario, you can take it back to a recycling center, and you already, when you buy it, you pay a recycling fee already. So there is a mechanism. And I think we do need to pay attention to this, because there is a lot of waste. If people, there was so the history of the filter is very interesting. It came on because people were complaining about the pieces of tobacco coming into their mouth, and it wasn't seen to be very sophisticated and feminine, essentially, is at the time, as they called it, in terms of smoking non-filter cigarettes and Turkish cigarettes, etc. So to differentiate it, they put on this filter and had different colors and different types, the brown and the white and the whole bit. And so a ban, it'd be very interesting. I mean, if you make cigarettes, so would it be less appealing, and whether people would not, and the question is whether they will get, external filters to put on is another one to think about. But it's a great question. I don't know, I have enough information. It could be that people will get these non-filters and then buy those other external filters and put them on. And if those are not single use, then you've really reduced the amount of disposal of things that don't biodegrade.
Yeah, great discussion. Thank you.
Yeah.
The next question or comment, I feel the recommendations are still abstinence oriented for youths. If there was something about why they use flavors, friends, etc., the amount they use or when they use at a party or in the school's bathrooms. Do you have a comment for that, Dr. Selby?
Yeah, we felt that this is, so the youth, the reasons why you will use varies from, social pressure, and their patterns of use can be varied from happen to be going to, a party, and they get together and they use and they share, and they don't actually do it daily. And then you're seeing this other group that is really needing to vape and feels that they've lost control. They're, demonstrating, symptoms of dependence very early. And then these are the ones vaping in the bathroom, in the school, etc., and canceled in class and those kinds of things. So I think we, when we come up with a guideline, I think it has to be really, we have to be careful that we understand that these are guidelines, these are not rules, and that they need to be applied to the population appropriately, and which population. So, for example, if I've got a young person coming in, and we are actually seeing consults, adolescent medicine physician is seeing consults of people who are vaping and feeling addicted to vaping. This kid has had school problems. This kid has been using cannabis. They've had disruptions at home. They're depressed. They've been cutting themselves. There's all sorts of stuff going on in which vaping finds itself. So that's a very different approach. And these guidelines will not apply to just say, oh, just stop, because this kid is kind of that, they've got a whole bunch of other things going on, and helping them to get on the other side of this, it requires a whole bunch of interventions rather than just the traditional, set a quit date, stop your vaping, and go on with your life. That's not the, it's not the incidentally addicted vapor that we're trying to treat here. So.
Great, thank you. Next question is, what are your thoughts about the evidence of the gateway effect that has appeared in observational studies, but isn't reflected at the population level?
Yeah, that's, it's a great, so gateway became really popular from some animal studies done with cocaine, it's a very compelling thing, right? Like, you get exposed to one thing and it makes you want to use other things. And what we have to understand is that these are associations. Just because A happened before B doesn't mean A caused B, and there could be other factors in play, and often there are, that can cause, or that can account for this observation. And so one of the issues around gateways are, I always look at this gateway as that we are too narrow in thinking about a gateway. Maybe for young people, it appears like it's a gateway in, but for the established smoker, maybe it's a gateway off. So it could be an on-ramp for some, and it could be an off-ramp for others. The question is, at a societal level, how do we make it more, like in the UK, more of an off-ramp than an on-ramp? So for example, in the UK, the NHS offers vaping devices as part of their stop smoking service, and it's the most common off-ramp medication that people are using. So the gateway, I feel, is we do not have enough information, and I have, again, it's the definition, it's the who are you looking at when you look at these small observational studies versus the whole population. And so therefore, if you only focus on a small group with a high risk to begin with, who are going to land up being a gateway, then you've got a selection bias right there in the population you've studied. So you're going to end up seeing what you were wanting to see, because you picked the patient population most likely to go on, versus when you look at a general population, maybe it isn't so. Okay. And I see the last one.
Thank you. Great comments about the selection bias there, sampling bias. Next question, and which is the last one for now, from Lori again. Could you please comment on COVID and using, I guess, COVID as a rationale or for the benefit for switching from smoking to vaping?
Okay, great one. So I don't know if you saw this, very early on in the pandemic, some papers came out of China showing that people who smoked were less likely to get severe COVID. And that started a whole flurry of discussion that one, smoking is an immune suppressant. And as now we understand COVID, you get your first part with the first 5 days is called the infectious type, an inflammatory, followed by the inflammatory period where your cytokines are going crazy and you'll end up getting all the, multi-system shutdown, and so because of uncontrolled inflammation. And so somehow smoking is preventing that. And so people will end up with a milder case of COVID. And in fact, people then sort of said, theoretically, there was a paper written that said, yep, it could. Nicotine does actually, the nicotine receptors do through the vagus nerve modulate the immune system. And so, yes, we should study this. Again, there was a potential sampling bias there in terms of the studies studied in China, and therefore it could have been a spurious observation. And so there is an ongoing study to look at nicotine for this. More recently, from the UK data, it's come out that the people who smoke were less represented in the hospital data. And again, these are associations, there's this causation. On the other hand, when you look at all the studies for high risk, people who are high risk of developing severe COVID, smoking is considered a high risk factor. And so should this be a time to help people who are, to quit smoking? Absolutely. We've got, with our Stop on the Net, which is the online enrollment, we're getting 3,000 people a month on average coming in to quit from across the province. And and our stop program during the pandemic through health systems, it took a bit of a hit because people had to stop enrolling from all these settings because they got pushed to other things, but it didn't go down to zero. And it's bounced back tremendously. So people did not forget about prevention during COVID, and they continue to come in. We published a couple of papers of that. So should we then ask people to switch to vaping? I don't see why not if they're not able to quit otherwise. But here, I just want to be completely transparent with you. This is where the state of the evidence is. Overall, we all think, yes, people should not smoke. COVID and smoking don't go together. And then, of course, the pragmatics of it. I'm really concerned of people, especially in congregate settings, where they have to mask and they go out to smoke, but they then use the alcohol. Why, they use rubbing alcohol in their hands or whatever, and they end up lighting, handling a lighter, they could burn themselves. So be really careful in those settings. So overall, my advice is quit. If you can't quit, vape, and if you are going to continue to smoke and you have to wear masks and hand sanitizer, etc., be careful you don't set yourself on fire.
Always good advice.
Yeah.
Last question. We'll take this last question from Lori, and then we'll switch back to the presentation. We have some webinar feedback questions. Could you please comment on your dissemination strategy and the benefit of promoting the guidelines in workplace health programs?
So thank you. So our dissemination strategy is dependent on the budget. So for the most part, dissemination for me is more, at the end of the day, creates awareness. In my work, I strongly believe that implementation is where it's at, and we need to really think about implementation. But often we are funded to do dissemination. From disseminating in a workplace, it depends on the workplace. If and what is the purpose of that workplace in that user's health? If that workplace is offering all options, and it's part of a workplace policy, let's say a construction site where you want to make sure that people are, then it might be very different than if it's a food service industry, for example, or some other hospitality, or depending on the workplace. So I think making people aware is always a good thing. I am a strong believer in people making an informed choice. And in this day and age, if you are seen as the trusted place to go to make that informed choice, then I think it's really helpful. If you have a good relationship in that workplace, I would put these kinds of things as part of the full package. Yes, the first thing is to quit. If you can't, with the evidence-based things, what do you do if you can't? Or if you don't want to, and how do we help you get there? So I think that allows that person to then have the options, as opposed to nobody showing up for the health because all you're going to talk about is only quitting and nothing else.
That's great. Thank you so much.
Okay.
So just thank you so much to everybody for participating in the questions. I think this provided a really excellent discussion. Really put Peter in the hot seat. So really enjoyed this discussion. Coming back to the main presentation for a few minutes. At the NCCMT, we're always interested in hearing about how things are going in terms of EIDM at your place of work. Especially now during the ongoing pandemic, with current challenges, competing priorities, redeployments. We are also available to support public organizations in EIDM practice through consultations. We do tailored webinars, workshops, partnerships on specific projects. We're always happy to discuss potential collaborations. We would also greatly appreciate your feedback on today's webinar. We do look very closely at the feedback that we receive to make sure that our webinars are meeting the needs of our audience. So you should have a poll having popped up on your screen again. We ask that you please answer the 3 questions and submit your answers. I'll make sure that I wait a few moments for those answers to come in. I know I certainly enjoyed the presentation and the discussion today. I think some really excellent questions and clearly some very keen folks in the audience. So really fantastic. So thank you so much to everybody for submitting your answers. Again, this is very valuable for us as we continue to hopefully improve quality internally and report back to our funder, the Public Health Agency. So moving forward, if you are interested in upcoming webinars, you can find those on our website. You can also follow us on social media. One of the best places is Twitter at NCCMT, and as well as through LinkedIn. And you can also sign up from our homepage to our newsletter, and we'll always make sure that we include upcoming webinars in the newsletter as well. We certainly hope to see you at future sessions as you're able to join. With that, I'd like to once again thank Dr. Peter Selby for that excellent presentation and really excellent discussion. They did not go easy on you, I think, with the questions. So it was great. Really, really great discussion. Lots of things I hadn't considered. So really, really wonderful. So if anybody does have any more questions about the webinar, about getting your hands on the slides, or about the low-risk nicotine use guidelines as well, please get in touch with us. We can always connect you with Peter as appropriate as well. So please don't hesitate to reach out. So Peter, thank you so much. This really was a wonderful session. And I do wish everybody an excellent rest of your day, and take care.
Thank you so much, Emily. And thanks everybody for your questions. I really enjoyed it. And as I said in the chat, I've had 2 teenagers who call me out every day. So I was prepared for anything.
That's great. Great training. That's wonderful.
Great training. Yeah. They train you well. All right. Awesome. Have a great day, everybody.
Take care. Thank you so much.
Thank you. Bye.